and thank you for all who are joining us this afternoon. Continuing on with our spinal cord injury lecture series that basically turns over every 6 months. So today we're going to be talking about neuroplasticity after spinal cord injury, reawakening limbs. I know there's a lot of questions about this. We'll be talking about the role of physical medicine and rehabilitation in neuro rehab. I'm going to be talking a little bit about exercise prescription for health versus neuroplasticity, and then talking about the issues with neuropathology that are essentially barriers to a cure for spinal cord injury. How can we overcome that as we're looking for appropriate interventions for gait and recovery after spinal cord injury? So just to kind of start us out again, basic exercise physiology. Several things that we do in the exercise sciences realm, including body composition assessment. The gold standard is 4-compartment modeling, but we also look at visceral fat. That's not going to be the focus today, although you all know that I have very strong recommendations in that regard. Reducing coronary artery disease risk is a part of an exercise prescription oftentimes, and that can be looking at insulin sensitivities, hypertension, lipid profiles, and vascular inflammation. Aerobic exercise prescriptions, which may include energy expenditure at rest as well as during exercise, and then looking at different types of substrate utilization. With that regard, when we look at spinal cord injury, we also do need to consider thermal regulation because of the autonomic dysfunction. Anaerobic exercise, looking at strength and power, adaptations and hypertrophy. And then motor control and neuro recovery. Not something that you typically learn in an exercise physiology didactic lecture series. You all know, or I hope you know, how to provide a prescription, medication prescription, or some sort of intervention prescription specific to exercise. These are the things that I expect our residents to be completing in terms of components of the exercise prescription, including diagnosis and comorbidities, the goals, and the goals need to tie together the specificity of training with regard to the specificity of testing that you're going to be using, identifying the limitations as well as the environment, and then going into the mode, frequency, intensity, duration, and progression of exercise. This is all tied together with an exercise prescription. When we talk about exercise for spinal cord injury, there are a number of things that we can consider. And remember that as you're putting together the exercise prescription, the goals are perhaps one of the most important things that we need to agree upon between the consumer and the clinician. So are we looking to improve strength or endurance? Are we looking to see body composition changes? Are we looking to reduce those coronary artery disease risks? To reduce or stave off osteoporosis? Are we looking for increased productivity and well-being? Using exercise as a way to reduce stress, or improving mobility and ambulation. So, I've put together exercise prescriptions in different manuscript forms, different book chapters and whatnot. You can again look at cardiovascular strength, power, flexibility, and mobility types of exercise. Fairly recent, Warburton's SCIR publication. You remember that SCIR stands for Spinal Cord Injury Rehabilitation Evidence. This was recently updated by their group in 2018. And they talk about using functional electrical stimulation training for a minimum of 3 days per week, at least for 2 months, to improve essentially cardiovascular fitness. Aerobic and FES exercise may lead to clinically significant improvements in insulin sensitivity and dyslipidemia. And then body weight supported treadmill training, BWSTT, can improve indicators of cardiovascular fitness and health, both with complete and incomplete tetraplegia and paraplegia. So it's kind of our starting point as we think about an exercise prescription. I want us to step back for a moment and talk about spinal cord injury itself. You all know that the central nervous system is comprised of brain and cord, and at the level of the cord, a spinal cord injury could influence the somatic nervous system and essentially impair sensory, so dermatomes, as well as motor or myotome function, depending upon the level of the injury. You also recognize that the autonomic nervous system has a role in the central nervous system, with the sympathetic nervous system lying primarily in the thoracolumbar regions of the cord, where it integrates with peripheral nervous system and central nervous system. Parasympathetic nervous system obviously includes cranial sacral nerve elements as we look through this. So the cellular components of the CNS, and this is both brain as well as cord, but I'm going to be focusing in more on cord, recognizing that only the nerve cells within the cord are actually conducting electrical impulses. That is, only those nerve cells are sending information to the brain with regard to sensory function, or from the brain with regard to motor function. So the other 90% of the cells within the spinal cord are essentially glial cells, and those cells support, nourish, and insulate the neurons, but they do not of themselves conduct nerve impulses. And so a number of different types of these cells, as we're looking through there, the oligodendrocytes in the central nervous system provide myelin to help with saltatory conduction within the CNS. The astrocytes are nutritive cells that take nutrients from the capillaries and help to get them to the neurons themselves. And then you have the microglia. These are essentially phagocytic cells cleaning up the environment, and particularly after an insult to the cord itself. You all recognize that there are decussation of pathways, and so as we look at the first 4 of these, I'm talking about sensory function. Pain and temperature information comes in from the peripheral and crosses over approximately 2 levels above where it comes in, and then ascends the contralateral cord up to the cerebral cortex. Position, vibration come in, and they ascend, those cell structures ascend the cord to the level of the medulla, where they cross over, they decussate at the level of the medulla to go to the opposite, or the contralateral somatosensory cortex. Light touch, as you all know, is being conveyed up the cord, both ipsilaterally and contralaterally. So ipsilaterally, it crosses over at the level of the medulla, but you also have that light touch sensory information coming in at that level and ascending on the contralateral side. Unconscious proprioception is conveyed through the spinocerebellar pathways on the ipsilateral side of the cord to the ipsilateral cerebellum. And then the motor cortex sends information from that cortex to the contralateral. It decussates over and descends contralaterally through the cord as we go through there. We talked about before, but the autonomic nervous system, the sympathetic nervous system arises from the thoracolumbar regions of the cord. And as we've talked about before, it integrates with the central nervous system. It collects sensory information and puts out through its postganglionic neurons adrenergic information to cause fight or flight response. Parasympathetic nervous system arising from the cranial sacral axis is about rest and digest. So all of that is happening within the cord. Now the cord is the size, remember, of your little finger. at about the level of your neck. And the cord has these tight relationships. So all of these sensory bundles that go together, they're insulated, as you would think of insulated wires, for example. They go on specific tracks as they ascend the cord. And similarly, your motor information coming down the cord is going to lie in specific tracks as well. The somatotopic organization is such that you have your sacral, both sensory and motor fibers. The sacral portion is on the outer rim of the cord, and then you have thoracolumbar and cervical fibers that are more centrally located. And when damaged, this area can lead to what we call the central cord syndrome. So just a reminder, this is a very simplistic cartoon, but as we consider the conduction of electrical impulses, that's only 10% of the cord's volume. 10% conduct information from the brain down the cord towards the rest of the body, but it also includes those ascending tracks that go up the cord, again, on very specific tracks as they go through. At about 1 centimeter intervals as you go down the cord, you have sensory information coming in, as well as efferent information going out through the ventral portions of the cord. And you have interneurons between them that can be facilitatory or inhibitory as you consider this. And so damage, again, this is a very simplistic cartoon, but damage to the cord is going to disrupt the origin of some fibers. It's going to basically block appropriate transmission of both sensory and motor function through the cord as it affects all of these pathways. So let's just fix it. That's the plan, right? But it's not as easy as, for example, doing a heart transplant, which is not easy, by the way. It's not as easy as putting stem cells into the heart to help recover myocardial tissue. In fact, when you consider repairing the spinal cord injury, remember the things that have occurred because of the injury. You have your primary and your secondary injuries that occur within the cord, and ultimately within days and weeks, basically, you start to develop a glial scar in 360 direction around the site of the injury. And within that area is often a cavity that needs to be traversed somehow if you're going to have appropriate communication fore and aft. Somehow we need to figure out how to, if we're going to put neurons or get new neuron growth through this damaged area, we're going to have to break through that glial scar. We're also going to have to find a way or a scaffold for the new nerve fibers to grow across. So potentially we could put in Schwann cells or stem cells to be able to do that. And both of those things are being done in animal models and to some extent human models even now. You would also have to recognize that new cells growing through here are going to be attacked by a number of inhibitory proteins. So no-go proteins, myelin-associated glycoproteins, tumor necrosis factor alpha, and nuclear factor kappa B, all within that space of the cord, are hostile to new nerve growth. And so somehow we would have to find a way to disinhibit or actually inhibit those inhibitory proteins to allow safe passage for new neural cell growth across the area. New nerve cells also require growth factors at very specific times in very specific concentrations within the cord itself. And so that includes all of these nerve growth factors, brain-derived neurotrophic factors, glial-derived neurotrophic factors, etc. But let's suppose that we could make a cocktail, break through the glial scarring, develop a scaffold, and get past all of those inhibitory proteins. The one thing that we would still have to worry about is guidance. How are those nerve cells going to know who to communicate with above and below? And so that lack of directional guidance without appropriate chemotaxis or structural bridges could potentially lead to misfiring, neuropathic pain, increased spasticity, and those types of things. So it's no small thing to recover after a spinal cord injury. There have been a number of preparations, and I just don't have time to go through all of this, and so I'm just going to provide a few for some thought as we continue in this idea of neuroplasticity. Olfactory and sheathing glial cells were reportedly used in a Polish firefighter. He had a stab injury to his cord in 2010 and essentially had an Asia Impairment Scale A lesion at T11, T12. After the OEG, so olfactory and sheathing glial cell intervention, he reportedly improved from an Asia A to an Asia C. Now, lots of issues to consider here. We have to suppose that folks understood the Asia Impairment Scale very clearly and didn't miss out on function, or that there were two separate systems that were being utilized as we progressed. Remember, the Asia became the INSCI, and we've had several iterations over time. But the bottom line was that they were reporting some improved function for this firefighter, and so that brought with it a lot of hope. Carlos Lima out of Lisbon, Portugal, has been working with olfactory and sheathing glial cells since around the turn of the century. And basically what they're doing here is they are harvesting nasal mucosa and then transplanting those into the damaged region of the cord. Why would they do that? Nobody knows. No, that's the nose, never mind. Olfactory mucosal cells are multipotent, and they include precursor and stem cells. The olfactory mucosa is immune privileged. Now remember, what's the relationship here? The relationship is the olfactory nerve. So you've got nerve tissue from that. So essentially you're taking this immune privileged material from the same person and then implanting that into the cell. For Dr. Lima's protocol, he was looking at folks under the age of 40 with spinal cord injuries, motor complete from C3 to T11, who were more than 6 months out from their spinal cord injury. Now, this was not a randomized controlled trial. This was a surgical case series, and he reported out information with regard to motor and sensory scores from the Asia Impairment Scale for outcome assessment. Remember that for motor scores, you can have up to 100. For sensory scores, up to 112 as you go through there. And the cost of this to participate, if I have a spinal cord injury and I wanted to participate in this trial, it would cost me approximately 30,000 American dollars plus my transportation to get there and back, et cetera. So what he had reported out in 2006 was for those folks who were enrolled. Now, it was interesting because even before the publication came out in the Journal of Spinal Cord Injury Medicine, he had reported at conferences, and essentially the protocol included getting this 1 to 2 centimeters squared olfactory mucosal harvest, cleaning and cutting those fragments, and then implanting those into the spinal cord donor site. They had over 26 subjects enrolled, but in this case series, they only reported on 7. Time since injury was 33 months on average, and on average, they saw a improvement in light touch sensory score of 13 points, and a pinprick sensory score improvement of 12 points. Now notice the standard deviations, though, that are as large as the improvements in some cases. They also reported, in terms of upper extremity motor function, an increase of about 6 points.
Okay.
Sorry, my phone is picking up on my speech as well. Upper extremity motor function improved by about 6 points in 3 of the individuals with tetraplegia. But what was reported in the manuscript, what you can find in the literature, were a little bit different numbers. So they only reported out in the literature on 7 subjects. And they reported out a sensory score improvement for light touch of 20 points, for pinprick of 20 points in 7 individuals of the 26 that they had previously noted including in the study. And they showed a 6-point improvement in those individuals with tetraplegia. The other thing was many of these folks came back to the United States, came from the United States, but came back to the United States and participated in intense locomotor training, up to 3 hours a day, 5 days a week. And so we don't know to what extent any improvements that they might have had were due to the olfactory and sheathing glial cell introduction, or were due to intense locomotor training. There was another study going on around the turn of the century as well. Dr. Wang out of China was using olfactory and sheathing glial cells from fetuses, and this was conducted in Beijing, China. I've got the overall scores listed out here. These were the improvements that they saw. Their subjects included 139 men and 32 women, so for a total of 171 individuals. Ages 2 to 64, just saying. Their mean age was 35 years old, and they were anywhere from 6 months out to 18 years after their spinal cord injury, but the mean was 2 years out. The intervention itself included a block laminectomy and then the injection of 500,000 OEGs above and below the spinal cord injury with tight dural closure. And then they did an ASIA exam, is what was reported at 8 weeks post-intervention. So these are the changes in motor scores, light touch, and pinprick sensations, as you can see. Note also that oftentimes the mean increases that they reported out have large standard deviations. In some cases, the standard deviations significantly larger than the improvements themselves. Oh, and is it appropriate to use mean and standard deviations with this kind of scoring? And of course, the answer is no, because this is ordinal data as we go through there. Currently, this is changing, I will say, and I need to update this slide a bit. There are some protocols that are moving forward with stem cell administration across the world, and so I apologize for not having this completely up to date, but next time I give this, I will include a few of those studies as well. What we haven't seen for sure is a significant improvement, significant enough to make this a standard of care. Again, a fairly expensive, on the patient's side, this comes out of pocket, participation, and then many of these folks participated in random rehabilitation. So what should we consider when we're looking at olfactory and sheathing glial cells or stem cell trials? There are still concerns and controversies. Has there been adequate preclinical foundation? Have we appropriately characterized the implanted cells? What are we looking at in terms of outcome metrics, and what is the supposed improvement caused by? So if you're using glial cells, would you expect those cells to develop into neural cells, for example? That's just one side of this. So I don't think this is quite ready for prime time. I will say that I continue to have folks question whether or not I should participate in this type of a trial. And you have to have a good relationship with your patients and or subjects, because you want to continue to have a trusting, supportive relationship with them, but you also want them to understand the pros and the cons of participating in these kind of trials. More on that a little bit later, but the bottom line is caveat emptor, or let the buyer beware. And then finally, should we participate in the follow-up assessments? If I'm a clinician following a patient, they go and participate in this trial, should I be involved with reporting changes in their function over time if I wasn't one of the investigators on the trial? That's a bit of a gray area as we go through there. So how can we go about repairing the neural network? We can't just push the two broken edges of the spinal cord injury together. That doesn't work out. Again, you have to find a way to allow appropriate communication, sensory to sensory, motor to motor, interneuron to interneuron as we go through this. So there is a role for exercise with regard to neuroplasticity. So what is neuroplasticity? Essentially reorganizing structures within the brain and spinal cord through the formation of new neural connections that would compensate for injury and or disease. And hopefully neuroplasticity allows the person to adjust their activities to be able to respond to new situations or changes in their environment. So what does rehabilitation neuroplasticity look like? We should first take a look at what are we trying to do to achieve. So coming back to our goals, what are our outcome metrics going to be to make sure that we are appropriately documenting improvements? So we have behavioral opportunities, looking at sensory, motor, and autonomic recovery. We have physiological rehabilitation that we consider changes in reflexes and improvement in motor evoked potentials, for example. We can look at structural changes. So is there axonal sprouting, dendritic sprouting, new nerve cell development within the cord? We could look at cellular synaptogenesis and synaptic strengthening metrics, and then from the molecular level, is there an upregulation of neurotransmitters and neurotrophic factors or alterations in gene expression? So all of these would be considered in terms of outcome metrics, and so these are typical scores that we can use depending upon which outcome metric is our particular goal. Now the hard thing is just getting investigators to agree upon these outcome metrics, much less the investigators and the consumers. And so you have to know going in what you're hoping to achieve, and then that should align with your outcome metrics as you move forward. So if we're hoping to see motor and sensory recovery, we can use in-ski examinations to identify the level of injury and the ASIA impairment score. We can look at function with regard to functional independence measures, the quadriplegic index of function, or the spinal cord injury measures. Those are all ordinal data, by the way. Everything I've mentioned so far is ordinal data. Ambulation, you can look at overground walking speed. So now you do have some, not just, you have a zero base. So this is not nominal, it's not ordinal. It's beyond ratio data. So basically you have a 0 point that you can look at as well. So walking index for spinal cord injury is a bit more subjective and plays into ordinal data, but the kinematics and EMG activation, that's very tight parametric data as we move forward. Certainly we can measure strength and endurance, looking at isokinetic joint torques. We can look at 6 or 12-minute walks, so the distance is achieved. We could look at functional imaging. So there are improvements in functional magnetic resonance imaging or PET scans. And then we could use some electrophysiology, H-wave reflexes, somatosensory evoked potentials, transcranial magnetic stimulation as we move forward. So I won't beat this to death. We've talked through this, recognize that it's helpful to some extent, but when you've got 100 points on motor and you have an incomplete injury, it becomes a little bit iffy how much there was actually functional improvement tied to changes in motor scores. Certainly we can be looking at spasticity, but what does that mean? Are you wanting to see reduced spasticity with improved function? So you have to consider how you're actually going to measure and report this, and is it going to be tied to function or something else? Ambulatory function, so using partial weight bear treadmill training and or overground walking is something that can be considered. The functional imaging we talked about, and I'm going to share some data with each of these categories, by the way, as we go through. And then electrophysiological studies, we kind of talked through this as well. And actually, one of the former investigators here at the Miami Project, Blair Calancy, has continued to look at changes in H-wave responses. I believe he's up in Syracuse, New York now. And then transcranial magnetic stimulation or epidural stimulation is something that we're going to talk about as well. Should we be looking at somatosensory evoked potentials? Remember, when we do that, we're looking at improvement in function as it sends the cord in the dorsal columns. And then I want to talk through a little bit of the locomotor training after spinal cord injury as well. So let's see if this will work. This is one of those moments where you just sit back and you look at this and you say, wow, that's amazing. So these little hummingbirds are thinking about every single little beat and how fast do their wings go, up to 280. No, their brains would have to be huge to be able to modify each of those types of things. So what these birds are using are central pattern generators in their spinal cord. They get those started and then they can modify from that point forward. So central pattern generator is something that you hopefully will, there we go. Hopefully you recognize. So what is happening here, in the same way that you have pacemaker cells in the heart, pacemaker cells in the gut, you have pacemaker cells in the cord. And they initially were looking at these at insects and birds, and they found that once you started these pacemaker cells, they would continue to generate impulses. And when you look at quadruped mammals, basically, the location of these central pattern generator cells are in the lumbar cord of these animals. So it's thought that central pattern generators also are in the cord in persons with spinal cord injury, and this may contribute to reciprocal gait function. And we're hoping to be able to tie into that. And again, Blair Calancy's work back around the turn of the century felt like this may be a way for plasticity and regenerative sprouting. Again, the coordinated spinal networks. So walking requires modulation of these neurons within the central pattern generator networks. And it's felt that sensory feedback is required to modify the motor programs. So as we look at mammalian, and we started off with quadrupeds basically, they've demonstrated different areas, location of these central pattern generators in the rat or the cat. And essentially what's happening is you are activating these central pattern generators to start a hip flexion, knee extension, hip extension type of rotation on both sides of the body. When you consider the model for this back in 1910, that's not where this video came from, by the way. Sherrington reported out the possibility and used spinalized cats way back in 1910. Things have improved significantly since then, and in the 80s, as I was going through grad school, Reggie Edgerton was doing some really remarkable work at UCLA, where they were using spinalized cats. So they completely transected the cervical region for this cat, and they could put them on a treadmill and actually see them walking if you just hold the tail up. And so, but the remarkable thing was, as you continue to do this, you can kind of see the reciprocal gait. If you change the speed of the treadmill, for example, the cat would accommodate. Again, this is a spinalized cat. And so again, evidence for these central pattern generators occurring just to get them started, and then they can be modified through other sensory function. Whoops, I'm trying to move forward. So I want to share a little bit of information about locomotor recovery. I might have missed, no, I'm okay. So work looking at partial weight bear treadmill training or locomotor recovery kind of goes back to Werdnick's work, and that was, you know, in the late 1990s. And basically they were suggesting that neuroplasticity occurred with rewiring of existing pathways or a combination facilitating reflex activities and cortical spinal reorganization. So what this graph looks like, so let me take a moment just to explain this. So this is the number of patients who before training and after training had changes in their ambulatory class. Now what is that? So they reported this as 0, having no locomotor function, and so that would be right here. A 1 is a situation where the individuals require a 2-person assist to walk. The 2 was an individual could walk in the parallel bars with 1 person assist, and you see the changes before and then after training. 3 are those who could walk with a pickup walker and or a front-wheeled walker. And then 4 were the individual could walk with a single point cane or a Gatorade. And then 5 is those who could walk freely for at least 5 steps. And so Werdnick reported out 80% of wheelchair users with partial paralysis would gain some walking ability. And this is just with regular, I would say at the time, standard of care gait training. Now, they didn't see any significant recovery in those individuals with motor complete spinal cord injury. So they reported out a few years later, again, before treadmill therapy, after treadmill therapy, and then their following exams using these same type of scales showed some improvement in individuals using partial weight bear treadmill training. Now, just as a reminder, the walk is a controlled fall, right? But we've got a lot of things to consider as we consider reciprocal gait, being able to change your weight bear response from heel strike to loading, to the mid stance phase, to the terminal stance where you have heel off, the pre-swing, the initial and mid swing, and then terminal swing. And basically some of this requires double support where both feet are in contact with the ground, or single support. Again, going back to double support, single support as you go through this, as you can do the opposite side. And you can actually consider the relationship of different levels of innervation to activate certain parts of this response. As you consider the relationship between the lumbosacral innervations and their contributions to ambulation as you go through here. So all of this is something that we consider as we look for locomotor recovery. Now, Susie Harkema at the time was a physical therapist and exercise physiologist in Reggie Edgerson's laboratory. She has since taken over the locomotor training laboratories at University of Louisville. And basically they were doing what they had done with the spinalized cat with humans. And so using partial weight bear So the person is not holding their entire weight up. And then they have facilitation of gait with a therapist on each side and somebody behind. So this is called manual assist treadmill training. There is a tremendous amount of wear and tear on the therapists who are advancing and moving the limb through its range of motion, recognizing also that there is some sensory input in this process as well as the therapist is working. So again, I'm trying, there we go. So when we consider partial weight bear treadmill training, there was a tremendous multi-site trial that was put together by Bruce Dobkin, again out of UCLA at the time, and he had a U program grant, including Thomas Jefferson University, McGill University up in Canada, Ohio State, Rancho Los Amigos, and the Shepherd Center all participated. What they did is they had 146 subjects who had Asia Impairment Scale B, C, or D with a mean of 56 days post-spinal cord injury who they brought into the program. And then they randomly assigned them to either the partial weight bear treadmill training system, manual assist, compared to conventional gait training. And what they found ultimately was there was a trend, but no significant difference after acute spinal cord injury. Now, Tony Burns reported out in 1997 data that had information that would have been helpful to this group because he showed that 86% of folks with incomplete tetraplegia would regain some degree of ambulatory ability. Now, while Tony was involved with these trials, the grant had been written prior to his study coming out, and so it was underpowered. That's the bottom line. And so both groups showed some improvements, but they couldn't demonstrate efficacy for the partial weight bear treadmill training group because you know, as Tony had said, 86% of individuals with incomplete tetraplegia were going to regain some ambulatory ability anyway. Now, Audrey Hicks up in Canada looked at long-term partial weight bear training in persons with chronic spinal cord injury. They had 13 subjects with Asia Impairment Scale B and C. Their mean time since injury was 7.5 years, and they provided partial weight bear treadmill training 3 times a week for a year. Had an incredible 80% compliance rate. And what they showed over the course of the year, there was a reduction of 54% partial weight support. They increased their treadmill walking speed by 180% and increased their distance walked over 300%. And those improvements, this is kind of crazy, they went home, they didn't continue to do this partial weight bear treadmill training. Those improvements were sustained after 8 months of just normal activity. So there seems to be something wired in that we can change after a spinal cord injury. Now, Patty Winchester is a physical therapist who at Southwestern at the time, and I think Keith Tansey was there at the time, but they were looking at robotic body weight supported treadmill training 3 times a week for 12 weeks to see if they could demonstrate changes in supraspinal activation. And so they were using functional MRI basically and whiskey scores, whiskey, so that's the walking index for spinal cord injury, not the drink. And they essentially showed significant increased sensory motor cortical regional activation that wasn't present in the pre-training, with significant improvements in cerebellar function or at least activation as well. So we're still looking at, and this is one of the things that we'll hope to be doing here within the next month or two, year or two, will be to put together a very rigorous study. I would like to incorporate assessments of body composition and metabolic function, as well as locomotor function, comparing manual assist and robotic therapy. And so as we consider that, so again, this is the manual assist. This is the robotic therapy. So for example, this is the Locomotor. And the robot can move by itself. Now, the nice thing is there's a single therapist who is running the robot as opposed to 3 therapists in the manual trial. What is not clear is if you can have the same improvements using robotic therapy as you would see with manual assist. I would love to not have so much wear and tear on our therapists as you go through here. It's a little easier using a keyboard to do this kind of work than it is to be there beside or behind the patient and moving forward with things. Now there's some additional overground walking systems, and it looks like I'm running a little bit short of time, so I'm going to pick up the pace here just a bit. These exoskeletons include the Rewalk, Exo, and Indigo. And again, in the interest of time, I'll just jump through fairly quickly. The Rewalk system is about $80,000 in investment. I'm just going to make some very basic comparisons as you look at these. The Exo system is $130,000, a variable assist with smart software essentially to assist with this. And then the Indigo system is about an $80,000 system as well. The group out of Moss had done a great multi-center trial comparing the 3 of these and found that some were better depending upon levels of injuries than others. What we hadn't really been able to demonstrate though was a significant improvement in overground walking speed. There are some improvements in bone mineral density, for example, and balance and a few other things, but has there been a significant improvement in gait without the robotic device? Not really been demonstrated. I'd like to consider using a recumbent stepper in the earlier phases of spinal cord injury rehabilitation for those folks who can't stand and walk, to see if we can start to activate the central pattern generators in the lumbar cord. So for example, using a reciprocal stepper device where the arms and the legs are moving in reciprocal fashion, similar to ambulatory motor function, but not requiring the individual to balance and or sustain their body weight. So it'd be interesting to see if we could do in-home, maybe recumbent stepping, and then move forward to more gait training as we move forward. I've mentioned Susie Harkema. The group at Louisville, and several other groups, by the way, are looking at epidural stimulation. And I'll kind of leave today with the thought that you can do this transcutaneously and or with implanted electrodes. And basically what they're finding is that somehow the electrical stimulation to the cord and or points above that can unleash, if you will, some of the person's voluntary motor abilities. And so they've shown this with improved hand function. They've shown with improved lower extremity function. What we don't know yet is the mechanism through which we are actually seeing improvements. And Dr. Harkema's group has also demonstrated some improvements in bowel and bladder. Now, when I say improvements, those are all relative to, there's a beginning and then after training effect to this. But what we don't know is if these things have clinical significance yet at this point. And then Monica Niku, I think it's Monica Niku, who's up, I believe, in Rhode Island, has been looking at some combinations of spinal and cortical stimulations using transcranial magnetic stimulation, using epidural stimulation, both, and they've looked primarily at direct current stimulation, but at different levels of the cord as they go through this to see if they can improve voluntary motor function after this. There it goes. So future areas of research, obviously we need to make some absolute determinations on what are the variables that we need to use to be able to compare across trials. And then we need to decide on the appropriate training protocols as we look at this and do this in a way that folks are also going to be able to gain some functional improvement. I don't know for sure, but my guess is it's going to require combination therapies that include some pharmaceutical trial, growth factors and cellular proteins, as well as actual rehabilitation. So the international campaign for the cures of spinal cord injury paralysis, I wanted to just end with this. This panel basically includes physicians, scientists, government agencies, pharmaceuticals, non-government agencies, et cetera, who are trying to put together appropriate guidelines for developing future spinal cord injury trials. These guidelines are for the patient. So this document, and I'm happy to send this to anybody who would like to look it over, is approximately a 20-page document talking about guidelines. So investigators certainly need to know this, but if I have a spinal cord injury myself and I want to participate in a trial, what kind of questions should I be asking? And this is a very practical guide to talk about having a discussion with the investigators about safety, possible benefits, preclinical evidence. Is this a clinical trial or a pseudo trial? What does the protocol look like? If I participate in this trial, does that preclude me from participating in other trials? Obviously, payment and costs. And then how worthy is the investigator that is performing this trial? So helping folks to weigh the benefits and the risk as you go through this. And again, I'm out of time, so I'm gonna jump past this a little bit and just talk about, in summary, we need to be considering tying into neuroplasticity of the cord and potentially the brain. What and how can we do to rewire existing pathways or facilitate reflex activity and modulation of the central pattern generators? You know, there are additional exercise benefits. We'll talk about exercise at some point. Improved cardiovascular function, pulmonary function, autonomic as well as neuromuscular function. All of these are benefits of exercise, retarding the aging process, and then preparing the body for curative interventions. So I've just about used up my hour. I'm going to open up for questions, thoughts, concerns. This is your opportunity to help me understand a little bit more of what I just spoke on. So feel free, if anybody's still awake.
I have a question, Dr. Gator.
Yes, Dr. Felix, thank you for paying attention.
What do you think it would take for this sort of extended training with the exoskeleton or treadmill to be funded for, you know, health insurance or whatever for longer periods of outpatient rehab? What would it take for that to happen?
So we're going to have to come up with some pretty clinically significant outcomes. And again, those outcomes vary significantly, but could include, you know, does this improve a person's activities of daily living? Does it improve their independence? Does it reduce their lifetime risk for coronary artery disease or risk of other comorbidities associated with this? But we're going to have, what we haven't done well is put together enough clinical, and part of this is maybe our interventions just haven't been sufficient. But we're going to have to demonstrate a significant clinical improvement in decided upon metrics in advance that the insurance companies, by the way, are going to believe in. Yes, this is worthwhile. And then we're also going to have to do some cost metric studies and looking at relative to the intervention cost, do those long-term outcomes outweigh, the price that we're going to be paying for them? So there's a lot of work that we need to do, and that's part of the difficulty in getting any of these preclinical trial or clinical trials to market, because you can demonstrate some improvement, but if it's not, in the insurance companies or providers, if it's not from their perspective going to stave off other comorbidities, if it's not going to improve the person's independence and allow them to become more financially independent, for example, then we're going to have a hard time selling this.